Okay. Hello, my name is Dr. Diana Feldstein, and I'm one of the physician volunteers with the MAVEN Project. Thank you all for joining us today and all of our friends at our clinics. We are going to review EKGs for primary care with Dr. Carrie Horwitch. Dr. Horwitch, sorry, I have to get to my phone. I printed out too many things today. Dr. Carrie Horwitch is an outpatient primary care physician. She also is a certified specialist in care for people living with HIV. She has been in practice for over 30 years. For 20 years, she worked with the Virginia Mason Medical Center Internal Medicine Residency Program as an associate program director and key clinical faculty. She is a clinical associate professor of medicine at the University of Washington, Seattle. She is currently a member of the Board of Trustees for Washington State Medical Association. With that, I'm going to turn it over for you, Dr. Horwitch.
Thank you so much, and good afternoon, everybody. Why don't we go ahead and pull up the slides as that's happening. If you also have questions, I will try to sort of answer them along the way and not necessarily wait till the end. You can also put them in the chat or the Q&A. I'll try to keep an eye on both of those. The title for this talk today is called EKG Basics, and I really do mean basic. Let's go ahead and scroll to the objective slide. As we said, no disclosures. Okay, so what we're going to try to do with this talk is really, I think when you're going to read EKGs in an outpatient practice or even inpatient, if you do that, you really want a systematic way to consistently look at the EKG every time so that you don't miss any area. So I'd like to go through what my systematic way is to do that, and hopefully that will work for you. It's also important to recognize, when's an EKG really abnormal and what kind of abnormalities should you be looking at, and then that can help inform your workup and your next plan of care, as well as recognizing really life-threatening EKG findings that you would need to be calling 911 and getting that person to a higher level care as soon as possible. I do not have any financial disclosures, but I do want to say I am not a cardiologist. I am an outpatient internal medicine physician. I'm not going to discuss any treatment for any of the EKGs that we look at today. And most of the images that I have actually been taken from the internet, so I'm asking please don't reproduce those because this is only for teaching purposes. Next slide, please. So one of my reference books that I have actually had and updated, of course, since medical school is this one by Dubin. And the nice thing about it is it's very simple. He goes through a lot of the basics. He has some great images in there. And so if you did want to choose to get a reference book, this might be one that's very usable for you. Next slide. So what is an EKG? So an ECG or EKG, depending on how you want to abbreviate it, is an electrocardiogram, meaning it's an electrical picture of the heart being shown in a graphic area. Each of the leads, so there are what are called the limb leads. So that's 1, 2, 3, and then the AVR, AVL, AVF, and then you have the precordial leads, which are the V1 through V6. Those typically will always be on the top of the EKG. And then underneath that, there is usually going to be a 10-second, for most EKGs, rhythm strip. So some of the EKG machines will only give you one option for rhythm. Others, like this one, will give you 3. So it usually is one of the precordial leads, typically lead 2. And then you might get also another precordial lead that's like a V5 or V6. Next slide. This is how you place. So again, the limb leads go on the arm and then either on the leg or down below. And then as you can see, the precordial are the ones that go across the chest. And what we're trying to really do is to take an electrical picture of the heart from a lot of different areas to try to get a more complete picture. Now, remember, you're not going to see absolutely everything or every part of the heart by doing this, but we can get some very good ideas what could be happening in different areas, the atrium, the ventricles, and then the different parts of the heart, right and left, posterior, inferior, things like that. So why do we do an EKG? Well, we are doing it to look for predominantly rhythm and conduction disturbances. It is a good measure to try to see if we can find any current findings for ischemia or infarction. We can also see effects, electrolyte abnormalities, or medications that may cause abnormalities. Sometimes we can get a picture that the heart could be big. If we see, certain types of enlargement on the heart and where it shouldn't be. And then, of course, when somebody's in the hospital with a cardiac issue or need to monitor, there's the continuous monitoring where we can see, or even ambulatory monitoring, where people may have something that they wear for a week or so to see if there are any intermittent abnormalities or arrhythmias. What we do not get from an EKG is we do not get any information about how well the heart functions. So like an ejection fraction, that's from an echo, not from an EKG. We can't really determine any valvular abnormalities or anything like that on an EKG. Next slide. So when we think about the cardiac cycle, again, we want to think about it the same way we do our history, right? When we ask about pain, we might have a PQRST. Well, the cardiac cycle luckily gives us a PQRST as well. The P wave is the atrial depolarization. The QRS complex is ventricular depolarization. The repolarization of the P wave happens somewhere that's buried in the QRS, so we typically don't see that on our EKG. The T wave is the ventricular repolarization. The J point is the point right after the QRS before you get to the T. We sometimes see, now go back, please. Thank you. We sometimes see an upsloping of a J point versus an ST elevation. We'll show that later. That little wave at the end on this, which is not labeled, that is a U wave. That is never normal. So it is, if you see that, you should be thinking, could there be some ischemia? If it's elevated, you may be thinking that there could be electrolyte or magnesium abnormalities, and so those should be evaluated as soon as possible if you see a U wave. Next slide, please. Okay, so getting to our systemic approach to EKG. This is my system. And again, if this works for you, that's great, but I would really try to go through each of these things and keep the same system every single time. So I tend to start with what is the rate, meaning how fast or slow is the heart going? What is the rhythm, meaning is it sinus or not? Is there an axis deviation? Then I want to look at my intervals. And so the three main intervals we look at is the PR interval, the QRS interval, and the QT interval. And then, and I'll explain those later. Then we're going to look for, are there elevations or depressions? And again, we will look at P wave. Is the P wave up? Is it down? Is there a deep Q wave that shouldn't be there? The ST elevation or depression, and then the T wave, is it up or is it down? And then we kind of say, well, is there anything else? So that's sort of like, just looks funny. So, gosh, I'm sensing like, I see P waves and QR, but they kind of look funny. They don't all look the same. So that's what we would call the other or the abnormal. And that's where you might need to say something's wrong here. Now I need to put on my thinking cap and say, well, what could that be? Is it I just have perhaps a premature atrial contraction or a premature ventricular contraction? Or is there really something about this? Could there be like a sinus arrhythmia or something like that? So that's the other. So rate, rhythm, axis, intervals, elevations, depressions, and then anything else. Next slide. So looking at, and it's important that you know how the measurements are done on an EKG, because that helps you to determine, is an interval too long? Is the ST actually elevated or depressed or not? And so when we look on an EKG, we know from, so EKGs, you'll typically have one line that's a little darker than the other, and those are spaced. So 5 little boxes, which are the lighter lines, is a 0.2 second. The small boxes are 0.04. And then when we're talking the vertical axis, so measuring voltage, the small box is 1 millimeter. So I tried to blow up. This is from the book I showed you. I tried to sort of blow up what this might look like if it were magnified. Next slide. So let's start with rate. There are a couple quicker ways to determine rate. One is by counting the number of QRS complexes in a 6-second rhythm strip. Now, remember I said on most EKGs, it's a 10-second rhythm strip. So to get determined 6-second, you have to do a little bit of finagling to kind of cut off the extra 4 seconds and then figure that out. And then you just multiply QRS. So let's say if I were looking at this strip below, and let's say that's a 6-second strip, I have 3 QRSs. If I multiply that by 10, that would be a heart rate of 30, which is slow. Okay, so the way I tend to do it is, though, however, the sequential method, which I've blown up here below, and that is where you find a QRS. I try to find a QRS on one of the darker lines, darker vertical lines, and then you count each dark vertical line and lower by a certain combination. So here on this one, from one vertical line, the next line, that's a rate of 300. So if my QRS was at that, I would have a heart rate of 300. But here you go down again, that's 150. Then you go down again, it's 100. And then you get to your next QRS, and that's 75. So my rate in this strip is 75. Okay? We're going to practice this a little bit. It does take getting used to. So that's why I'm saying you have to try to find a QRS in the rhythm strip that lands on one of those dark things. Otherwise, again, you can be a little off because it helps with the counting. All right. So are there any questions on this right now? You guys may have already been sort of doing this or practicing this. Next slide. So how might we describe rate? Well, there's normal, which is between 60 and 99. Again, in some instances, over 90 could be abnormal for an individual. But by definition, 60 to 99 is considered normal heart rate. If it's above 100, that's called fast heart rate or tachycardia. If it's below 60, that's bradycardia or slow heart rhythm. So those are the only three. It's either normal, too fast, or it's too slow. Next slide. So would anybody want to try to tell me what the rate on this EKG is? And again, look at your rhythm strips. This is a 10-second rhythm strip. So if anybody wants to try, just jot in the chat if you think you can kind of use one of the two methods we talked about. I won't wait too long. If you don't want to guess, that's fine too. But if we use our method of counting, we're probably a little bit in between. It's not quite 75, so it's going to probably be a little closer to 80 for this EKG. Next slide. Next slide. Sorry. Okay. The next thing we're going to look at is rhythm. And here is where we need to determine, is it sinus rhythm or not? So again, these are really basics. There are several other lectures from one of our cardiologists through MAVEN that goes through a lot of different arrhythmias, bradyarrhythmias, tachyarrhythmias, as well as other EKGs. And you can also get tutorials in EKG reading if you want. So please reach out to MAVEN if you want additional discussions on EKG. So the key thing for a sinus rhythm is you need to have a P wave. The P wave has to be followed by a QRS complex. And is the QRS complex preceded by a P wave? And so that comes up important where you may have P waves, you may have QRSs, but there may be P waves that don't have a QRS, so that could be some kind of a block, which is different. So if you have all three of those criteria, then it is sinus rhythm. We try not to say normal sinus rhythm because, again, you can have sinus rhythm and there can be some abnormalities. So just say it's sinus rhythm or not sinus. You can look at your P intervals, so P interval to next, to see if it's regular or if it's spaced out. Kind of funny. And again, you can have sinus rhythm that is a normal rate. You could have sinus tachycardia, fast, or sinus bradycardia, slow. Okay, next slide. Next slide. Okay, so if we are looking at this EKG, it's exactly the same one we saw before. Would anybody want to just write into the chat? Do you think, so all we're trying to determine, is this sinus rhythm or not? I'll go back, yeah. Is this a sinus rhythm or not? So just type into chat. Yes or no. Go back, sorry, thank you. Okay, great. I have some brave people saying, yes, this is true. Yes, so you can see that on our rhythm strip, and I actually think the best rhythm strip to look at here is the number 2, lead 2. You see P waves, you see QRSs. The P waves are followed by a QRS, and each QRS is preceded by a P, so this is sinus rhythm. Next slide. Okay, so let's say this is the same patient. So is this, again, same question, is this a sinus rhythm? Yes or no? Okay, so here we're getting a little bit, yes, it is, no, it isn't. Okay, so yes, it is. It is a sinus rhythm, but you notice this is one of those things where, the P waves are not exactly marching up, but the P waves are followed by a QRS, and the QRS is preceded by a P wave, but it isn't regular. So this is sinus arrhythmia. Next slide. And so sinus arrhythmia, it's still a sinus rhythm. P followed by QRS, QRS preceded by P, but it was irregular, right? So the P waves there was some spacing, some were closer together. So sometimes this could be normal, physiologic normal in certain people. If you listen to the heart, you might actually hear that it sounds irregular. And this is somebody who, you may need to make sure what medications are they on, or drugs, substance use, thyroid condition that could cause that. If you see this in an older person, you need to think, are they on digoxin? So digoxin can cause all kinds of arrhythmias. Or could this be some sort of perhaps sick sinus syndrome or the start of that? So that may be somebody who needs further looking into for that. Next slide, please. Okay, so we've done rate, we've done rhythm. Now we're going to talk about axis. And the axis is the direction for what's considered the main vector of our depolarization. I will show you a slide in a minute. But normally our heart rate goes from the right atrium down into the AV node, bundle of His, down into the ventricles, the right and left bundle, and then out to the Purkinje cells. And so normal axis kind of comes from the right and diagonally down to the apex to the left. So when we think, say, it's a normal axis, we're looking at, and if you look at that little wheel, it's between from minus 30 to 90 degrees on that wheel. I think, no, go back one. I think the quick way to look at this and to know, is it normal axis or not, you look in the QRS of lead 1 and lead AVF. If the QRS is both up, that's normal axis. Okay, if we call it a thumbs up. All right, so QRS lead 1's up, QRS and AVF is up, normal axis. That's your sort of quick way to do that. Next slide. Now, if we have a right axis, so this might be something that could be affecting the right side of the heart. So you think about pulmonary embolism, hypertrophy, it could be ischemia related as well. Some people may have a normal variant of this, but that's less common. Then you're looking at a right axis where you're looking at the 90 to 180. And again, if you look at lead 1 and lead AVF, most of lead 1, the QRS is down. And in AVF, it's up. So this is right axis deviation. Down in 1, up in AVF. Okay, next slide. On the other hand, left axis deviation, typically we're going to be looking at things that may affect the left side of the heart, but again, there can be normal variants. It could be because the diaphragm's pushing, there could be hypertrophy, hyperkalemia, again, ischemia. Here, you're up in lead 1 and down in AVF. Okay? Up in 1, down in AVF. All right? So it's either 2 thumbs up, it's either down in 1, up in AVF, that's right, or up in 1, down in AVF, that's left. Okay? Normal, right, or left. Okay, next slide. Now let's go to the interval. So this is where knowing how the boxes are counted is important, that I showed you at the very beginning. So the 3 intervals that we typically will measure is going to be the PR interval, and anything 0.2 or less is normal, and you start at the beginning of the P to the beginning of the QRS complex. For your QRS interval, you start from the beginning of Q to the end of S, and that should be less than or equal to 0.12, so 3 little boxes, okay? For the QT interval, it's from the start of the Q to the end of the T, and that should be less than or equal to 0.44. And some of your EKG machines will do a corrected interval, which may be corrected for rate, still should be less than 0.44 or equal. In terms of segment elevation or depression, that's your ST typically, and it should either be flat or maybe or less than 1 little box. But if it's more than that, then that is considered positive ST elevation or depression, depending on which. And then same thing with inversions. Inversion just means normally the P wave and the T wave are up, except in one lead. But if it's depressed, that could mean that there's some underlying issue. Next slide. And when you look at the electrical anatomy, I think it is important for you to know which parts, which leads speak to which part of the heart. So when we think about the inferior, so the bottom of the heart, those inferior leads are going to be lead 2, lead 3, and lead AVF. So if I see a Q wave or an ST change in one of those leads, I really want to look very carefully at the other leads that speak to that part of the heart. I'm going to look at all the leads, but I really want to be sure, is it just one lead? And you need to make sure the leads are in the right place when you do that. Lateral is going to be lead 1, AVL, and then your V5 and V6 is going to speak to lateral. And then your precordial, the V1 through V4, is going to be the middle of the heart, so the septum and the anterior part of the heart. So again, it's really important that you know which parts of the EKG correspond to where you think the injury or abnormality could be on the heart. Next slide. Okay, so let's try to put this all together with a few cases. So a 22-year-old comes to clinic for routine health care. He has absolutely no concerns. He likes running, he exercises, works in a restaurant. You come in, his blood pressure is 110/70, his heart rate is 50. You listen to his heart with the stethoscope against the skin, and you don't hear any murmurs, and you feel that there's a normal S1, S2, the pulses are normal and no edema. Next slide. And this is his EKG. So what do you think his EKG shows? So remember rate, rhythm, axis, the intervals, and then depressions or elevations. So I know we don't have a lot of time, so I will just go ahead and answer this for you. So essentially we have sinus, there's P's and QRS's. This is bradycardia because it is a heart rate less than 60. Okay, and if we count it out, it's going to be 300, 150, 175. It's probably close to a heart rate of about 40, 45. Okay, it's hard to say if the axis is normal because the QRS in 1 is so small, but for the sake of this, let's say it's pretty close to normal. The intervals are all normal, and there are no obvious ST elevations or depression. There may be a slightly inverted T wave in V1 and AVL, but otherwise this is normal. And this would be potentially a normal EKG for a young, healthy person. Next slide. Okay. So if, however, you see this and you're not sure, or, maybe they're complaining of some other things, you could get a thyroid test just to make sure that this person doesn't have undiagnosed hypothyroidism. If this were an older person or somebody who is having, again, any symptoms, I might be concerned that this could be starting to get a block. Again, sometimes people start to get bradycardia first before you start seeing some of the others. Electrolyte abnormalities could also do this, or is this person taking beta blockers or something else that could slow the heart rate down? So just because I gave you a young, healthy person doesn't mean there could not be an underlying issue. So it's always good. You need to always make sure you're taking a good history and think of some of those other things that could be contributing. Next slide. Let's move to case 2. So here's a 45-year-old comes to clinic concerned about getting intermittent dizziness, some shortness of breath with exercising, but not having any frank chest pain. You don't have any history that you know about, and they don't describe anything. They state they're not taking any medications and not taking any illicit substances or alcohol. The blood pressure is 120/80. The heart rate is 56 when you count it. The thyroid exam appears normal. And again, the heart rate is a little slow, and maybe you kind of hear some funny extra beats that aren't just the lub-dub, lub-dub. You might get lub-dub, 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 blah, blah. So intermittent like that. You don't hear any bruits or murmurs. The lungs, our examination is clear. And remember, lungs and heart should always be listened to stethoscope to skin, not through clothing. Next slide. So does anybody want to see if you can figure out this EKG. So again, rate, rhythm, axis, the intervals, and then elevation or depression. In case anybody is typing furiously, I will give you a few seconds. Go back, please. Thank you. Okay, I'm not seeing anything appear yet in chat, so that's okay. So what we can see is the rate. Now I'm looking at the rhythm strip and it seems a little variable. At times, it's bradycardic. At other times, it appears normal. So there's something going on here that is not normal. We also don't really have sinus. There are P waves and there are QRSs, but not every P wave has a QRS, and not all the QRSs are necessarily preceded immediately by a P wave. And if we look at our intervals, we notice some of the PR intervals are normal. They're less than one of the big boxes, and others are longer. And then we have some P's and there's sort of nothing there. So yeah, so people have been saying there's some kind of block. There's some kind of heart block in here. So let's go to the next slide. So this is some kind of a heart block, typically AV nodal heart block. And again, that's where there is a delay between the stimulus from getting from the atrium to the ventricle. You may get prolongation of the PR. If there's only that's usually first degree heart block. There may be other blocks that would then go to second degree, and there's two different types, or third degree, which means you have atrial contractions and you have ventricular contractions, but they're really not talking to each other. So that is somebody who actually needs a pacemaker, okay? Because eventually that is going to be poorly compatible with ongoing life if that doesn't get treated. Next slide. So I found this poem online and I thought it was cute just to, again, try to help us remember, well, what are the different blocks and how do I remember? So it goes like this. If the R is far from the P, then you have first degree. Longer, longer, longer drop, then you have Wenke Bach. The longer is the P wave to the QRS, right? So you have normal PR, longer PR, and then oops, there's no QRS. If some P's don't get through, then you have Mobitz 2. So those P's may be regular, but then one of them doesn't go through. And if the P's and Q's don't agree, then you have third degree. So this may be a little ditty that you can kind of help you remember if you think you have a heart block. Next slide, please. There's also the bundle block. So remember as I mentioned, how the heart rhythms transverse. Go back one. Actually, you can go forward one, then I'll have you go back. Okay, so here we have most rhythms should start at the SA node. It will then travel to the AV node, which is that other node in yellow, through what's called the bundle of His, down into the right and left bundles in the ventricles, and then out to all the Purkinjes for the impulse. So now go back. If you have a bundle block, that means that either the right or the left bundle, there's a block somewhere. You typically may get a wider QRS, and you will also tend to get the RSR prime. So like little rabbit ears, depending on whether it's a right or a left bundle. And you can see that I showed some pictures of that as well. So remember, if the block is on the right side, the left bundle is gonna contract first and then the right. So that's why you will get two R's, okay? And same thing on the other side. If you have a left block, then the right's gonna contract first and then the left bundle. Next slide. Okay, go on. Okay, so in bigger form, here's an evidence of a right bundle branch block. And especially you can see looking in, say, V2 and V3, that you get the little rabbit ears. Okay, so you have two R's, RS, R prime on that. Next slide. And this is an example of a left bundle. It can be confused with sinus tachycardia, or even more concerning, ventricular tachycardia. But there are P waves there, and there are QRSs. And this could be somebody who may have had ischemia or has ischemia and got a block from that. So this is somebody that, if this is a new finding, this may be someone who needs some additional workup because this is not a normal EKG. Next slide. Okay, third case, a 55-year-old coming to clinic concerning about they're having palpitations, so just feeling funny. And people may not actually understand the word palpitation. So sometimes they'll say, is there any fluttering? Do you feel extra beats? So they may have different ways to describe palpitation. The person does have a history of high blood pressure and is on a thiazide diuretic. On exam, they do not appear ill. Blood pressure 130/85. The heart rate, you hear it, it sounds irregular, and its rate is about 110. But the remainder of the cardiac and lung examination is unremarkable. So let's go to the next slide. So what do people think about this? Again, we've got rate, rhythm, axis, intervals, ST elevations or depression. So is the rate fast or slow? Sort of, for sake of time, I'll just say it's fast. Tacky, thank you. It is not sinus, right? I'm not really seeing much in the way of P, or there's maybe some P's, but there really aren't P's followed by QRSs. It's kind of, so this is not a sinus rhythm. Okay. The interval lengths appear normal, and ST depressions, not exactly ST elevation or depression, although in V1, V2, there may be some J point change that could be depression. And so, yes, people are writing in the chat already. Yes, this is an evidence of atrial fibrillation, right? The atrium's just firing and its P's are all over the place and it's kind of moving around, and it's fast. Next slide. So this is probably, atrial fibrillation is probably one of the most common of the supraventricular. So supraventricular just means above the ventricle, usually in the atrium, tachyarrhythmias. And again, it means they're the random electrical depolarization. It can sometimes be confused with flutter, which tends to have usually a little bit more of a regular pattern. Can also be confused with other types of sinus tachycardia or very significant sinus arrhythmia. So that's why you really need to look at, is there sinus or not? And a lot of different causes for atrial fibrillation. It could be underlying coronary heart disease, congestive heart failure, valvular abnormalities, thyroid conditions, alcohol, drugs, medications. Sometimes we do it by things that we give people. So it does need to be evaluated, and it does obviously need to be treated, trying to find the underlying cause for it. Next slide. How about if it looked like this instead? So the difference here, as you can see, it looks like there's sort of like jaws or sawtooth. So this is atrial flutter, okay, with a variable rate. Okay, so that's one of the differences, a much more regular looking picture on the EKG This also similar differential in terms of what could cause this. If somebody is unstable and has this, they should be immediately gotten to the emergency room, and typically they would be cardioverted out of this rhythm. Next slide. Okay, next slide. We'll go to case 4. Okay, so a 58-year-old woman comes in. She's got intermittent chest pain. She notes that it's kind of dull, comes and goes. She saw a physician who thought she had heartburn because it was sort of started down here in her belly and moved up. The heartburn medicine helped a little bit, but also, she's just been feeling a lot more tired, but works 2 jobs. She has to climb hills to her home and just notes that over the past several weeks, it's gotten a little harder. Blood pressure is elevated at 130/90. The pulse is 82. The lungs did not show any abnormality, and the cardiac exam was not normal. So let's go to the next slide. Okay, so when we look at her EKG, again, rate, rhythm, axis, and then we look for the intervals, and is there ST elevation or depression? The reason to systematically go through that is to make sure we're not missing anything. So obviously, most people would go straight to the ST elevation or depression abnormality here, but you do want to run through the whole thing because, again, the heart rate here is slow. So it's bradycardic. And yes, you do see in the inferior leads, so 2, 3 and AVF, 3 and AVF have ST elevation. And then if you look at the precordial leads, you've got V1, V2 that show ST depression and V4, ST depression. So if this person is in your clinic, I would hope you would be on the phone getting 911 to come and take this person to the emergency room because this EKG is showing evidence of a myocardial infarction, probably of the inferior or posterior inferior area of the heart. And many women are actually misdiagnosed with abdominal issues when in fact they may be actually having cardiac issues with presentations of discomfort. Next slide. Okay, so again, and bradycardic can go along with that. The PR interval in that EKG was slightly prolonged. The rest of the intervals were normal. And yes, the ST elevations were present as well as ST depressions. There were also some very small Qs in 2, 3, and AVF, which again, the EKG was too small for us to really measure those out on this EKG. Next slide. And so let's look at a couple other EKGs that just show, so there's ST elevation MI, otherwise known as STEMI, where you actually do have ST elevations or depressions. And again, on this EKG, you can clearly see in lead 3, there are depressions. In lead 4 and 5, very significant ST elevations. Okay. So again, if it can be much more subtle than this. And many times when we see it in the outpatient setting, it usually is. But you don't want to miss it and get them as immediate care. Next slide. And this is what's called a non-STEMI or no ST elevation MI. And here you can see the ST is not up or down, but if you look at other things that are going in the wrong direction, you see T-wave inversions. And there are T-wave inversions in lead 1 and lead 2, which should not be inverted. You also see T-wave inversions in 5 and 6. Those should not be inverted. Okay, so again, you may be fooled. If you have old EKGs, that's very helpful because it's hard to know, is this new or is this something somebody may have had in the past? But again, if somebody comes in with a history and they're having, shortness of breath with exertion, or they're having some vague chest pain, and you see this on an EKG, I would be wanting them in an emergency room getting evaluated for an acute MI. Next slide, please. Okay, so we know that myocardial ischemia or infarction is a leading cause of morbidity and mortality in both men and women. Chest pain may be present, but it may actually be more subtle, and there may be some other signs or symptoms. And so you need to have sort of a high index of suspicion if they come in. Remember your PQRST for all of this. And we obviously would always want to intervene as early as possible. And again, remember, women may present very differently than men, so we want to be sure we don't introduce, a bias into evaluating people. Next slide. Okay, case 5. I want to leave time for questions, so I'm going to just go through these next ones pretty quickly. A 40-year-old female presents to the hospital with palpitations, also becomes some short of breath, may have had kind of these symptoms on and off, she thinks, for many years, doesn't take any medications. In your clinic, let's say, or in the emergency room, the blood pressure is elevated, 140/90. The heart rate's quite fast at 150. No murmurs, but the heart rhythm is irregular. And again, nothing on lung examination. Next slide. So what do people think of this EKG? Well, I think everyone can agree that this EKG is fast. And if we use our counting, it's at about 150. In terms of whether this is sinus, it may be, it's a little fast. It's hard to see on this EKG. But it may also, again, because we don't really see good P waves, it could actually be further down in the thing as opposed to coming from the atrium. Okay, next slide. And then if we were to slow it down a little bit, you can see these arrows are pointing to something on the QRS, and that is what would be a delta wave. Now, I will tell you, having done medicine for a long time, I have rarely, I've maybe seen a delta wave once. But if it's there, that can be very helpful to make a diagnosis for some person like this, because a delta wave usually goes along with a congenital condition called Wolff-Parkinson-White, WPW. Next slide. So this is an evidence of a supraventricular tachycardia. It tends to be fast, erratic, typically affects the upper chambers. And again, there are different types of SVTs. So they can come from different areas in the heart. And again, there are some genetic ones like the WPW and others. So again, these do need treatment. This is, I would be probably calling up my cardiologist and saying, how fast should I get them in to see you? What should I do for management right now with this? Because they likely may need other interventions from my specialist. Next slide. Risk factors, again, for SVTs, age, underlying coronary artery disease, congenital conditions, thyroid, diabetes, sleep apnea. So again, the list for many of these is fairly long. And so making sure you're looking for some of these anyways is really important, that we don't miss anything. Next slide. You do want to get, again, EKG. If there isn't anything urgent, again, they may need some additional testing, but a lot of times I'm already going to be talking to my cardiologist about next step for this person. Next slide. Okay, last case, 62-year-old has been taking over-the-counter famotidine, which is an H2 blocker for stomach pain. Saw the physician recently in clinic who also thought they were depressed and gave them citalopram, and also wasn't sleeping well, so put them on low dose of amitriptyline to help with sleep. And the patient came in and had an EKG done at the next appointment. Next slide. Okay, so the circle is helpful here, but again, if we're thinking rate, rhythm, intervals, ST elevation or depression. So here the rate is kind of borderline, but about 60. Rhythm, sinus. Our intervals is where we see a problem. So the PR interval looks normal, the QRS interval looks normal, but the QT interval is prolonged. Next slide. And the reason we worry about that QT prolongation is because QT prolongation can contribute to this finding, which is torsade de pointe, which is a form of ventricular tachycardia. And the more medications that can prolong the QT, the more concerning it would be that we could create a problem. There are some people who have congenital QT prolongation, but many, 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 many drugs can prolong the QT. Next slide. So we really need to be very mindful when we are prescribing medications that we know if somebody's already on a medication that can prolong a QT and it's really necessary to give them another medication that could also do that. A lot of times I will actually get a baseline EKG. I want to know what my QT is starting off. And certainly if they are on more than one drug that can prolong QT, I will sometimes monitor their EKG to make sure my QT is not prolonging, and I could be getting into trouble with that. Other drugs that could do that, methadone is a common one, and people on methadone maintenance or chronic methadone should actually have their EKGs monitored as well, at least annually, or more, clearly, if they're having issues or symptoms. Digoxin, again, another classic drug that can cause a lot of arrhythmia problems. Okay, next slide. So just going back on the key points, EKG, very important in outpatient. Have a consistent, systematic process for how you read it. Make sure that you look at some books and understand what is a life-threatening finding. And again, we do have MAVEN Cardiology for consults and more training if you want it. We can stop the slides, and then there was a question. Okay. Can I talk about some reasons that I order an EKG in primary care? Yes. Obviously, chest pain. I will typically order an EKG. And I typically will do that even if they may be younger, is because it is not unheard of that somebody could have a cardiac issue. If people are short of breath, dyspnea for some reason. And again, maybe that's a cardiac equivalent. I will get an EKG if they're complaining of palpitations or even dizziness. Like somebody who's just dizzy, again, looking for an underlying cardiac abnormality for that. In terms of hypertension, I think that because hypertension is so common, I don't necessarily get an EKG on every person initially. I think where it wouldn't be wrong necessarily to do that if you have the time, or to see if they may have had it for a long time, like maybe they have, high voltage, which could mean that they've had long-standing hypertension, or in someone whose blood pressure is not well controlled, you might want to do that. If somebody has hyperkalemia and you know that in the clinic, then yes, you may want to get an EKG to see, because if they have peaked T waves, again, that is not somebody I'm sending home, right? That's somebody I'm sending to the emergency room to get that treated right away. So yes, there are a lot of things. Fatigue, yes, I will sometimes also do it for fatigue. Again, because I may be missing an unexplained cardiac. So patients don't always come in with the history like we want to see, right? For like, oh my gosh, an elephant on my, I've had nobody come in saying they have an elephant on their chest. Okay, I have had a lot of people come in with vague symptoms and they may have an underlying cardiac issue. So I do order EKGs if I suspect that I want to look for any underlying change, if I can find it on an EKG, because it is something we can do in the outpatient and it can be very helpful to inform us. The last time I did this talk, I did get a question about, well, what does an EKG look like if you've got like pericarditis? And pericarditis, I will tell you, those are some of the scariest EKGs that I have seen. So for PE and pericarditis, probably the most common thing you will find is tachycardia, sinus tachycardia. However, what you may also get with those, especially with pericarditis, is you can get ST elevations in a lot of different leads. Okay. It could be like in all the leads, and you're like, now you're having palpitations when you see that. I will still probably send that person if I'm in a clinic where I don't have backup. I'm still sending that person to the emergency room because I don't know if they are having pericarditis because of an underlying COVID infection, other viral infection, something else, just some inflammation, or if they're actually having a myocardial infarction. So if I'm seeing those ST elevations and they're in my clinic and they're having chest pain, I'm sending them for further evaluation. Okay. I am not going to send them home and just say, it's probably just pericarditis. Let's just treat that. So I think, again, given where you work and what kind of resources you have, it's always, I think, okay to weigh on the side of being a little more cautious when you're talking about a cardiac issue if it could be emergent. Okay, we have 1 more minute. If there are any other questions, I just saw the one that I answered, but you can put them in chat or if you have other questions. Otherwise, again, please take advantage of some of the other MAVEN talks that will go into a lot more detail about other rhythm issues and just getting practice. And then again, if you do want, you can actually ask MAVEN for a tutorial specifically with consults and EKGs for yourself to get better at this. Believe me, as I said, I am not a cardiologist. If I see something, it's like I'm calling, I'm asking for some help. So, and I've been doing this a long time, so I'm never going to say that I know it all. And I think that's how we learn. So thank you
I
so much for your time. I appreciate you all being here.
Thank you guys. And like I said in the beginning, we will be emailing you. You will get the survey and you will be emailed with your CME. Just because I'm here, Dr. Horwitch, I just wanted to ask. I loved your case. I think all of your cases were great. One of the last case you mentioned, the guy who unfortunately had ended up with QT prolongation. You mentioned 3 medications in specific, right? He was on famotidine and he was on
Famotidine, amitriptyline, and citalopram. SSRIs, most of them are known to cause QT prolongation, as are the tricyclics and many other medications. Yeah.
Yep. I just wanted to hammer that home for medicines that I know
A lot of medicines can prolong the QT.
There's no there, and the other culprit that I always worry about is fluoroquinolones.
Oh yeah, yeah, which we should use very, very sparingly for a lot of reasons.
Agreed. All right. Well, thanks everybody.
Thank you. Thanks,
Bye-bye.
Diana. Thanks for your help.
Sure.